be talking about the next webinars and the next topics we will be covering. Our plan is to have one session per month and thus be able to expand it at the regional level and continue to update you on anything new that occurs in the field of tuberculosis. This webinar and several of the ones that we're preparing will have been worked on in very close coordination with the green light committees. And we would like to thank each and every one of the members for this very close collaboration with the regional tuberculosis team. I'd like to also add that we'd like to ask the participants to write in the lower part where there's Q&A, the question and answer section. Please put in any questions you may have, and we will respond to them as we receive them. Also, we have simultaneous interpretation so that you can choose the language of choice. At the lower part of the screen, you will see a globe that says interpretation, and there you can choose the language you prefer to listen to. With this preamble, I'd like to add to the presenters that if as much as possible, they stick to the time that has been allotted to them for their presentation. We will be reminding you 5 minutes before about the amount of time you have left so that you can adjust your presentation and keep to the time constraint. With this, without any further ado, I'd like to now call on Dr. Pedro Aderillo, our regional advisor in tuberculosis in the team, Dr. Pedro Avedillo, to welcome us and give you the goals of this seminar. Thank you very much, Francisco. Good morning, colleagues. This is Pedro Avedillo, Regional Advisor on Tuberculosis at the Pan American Health Organization in Washington, D.C. Thank you so much for your participation and welcome to this virtual regional session on the shortened treatment of drug-resistant tuberculosis. As Francisco has said, we are preparing a series of virtual sessions on several current issues in the area of tuberculosis. And we would like to specifically start with this series on webinars on the new guidelines dealing with the diagnosis of tuberculosis together with the Green Light Regional Committee. We will specifically talk about the shortened system regime agreed to by tuberculosis to those who are resistant to vancomycin and MRB. I'd like to begin by giving you some brief data on the status of tuberculosis in the region. As you know, drug-resistant tuberculosis continues to be a very important health problem worldwide, and it has makes us pay a high price for the people affected by this disease, as well as in communities and for the healthcare services. As you know, one of the major commitments we have made through the policy declaration of the high-level meeting on tuberculosis that took place in 2018, one of the numerical goals was to, by 2022, have 40 million persons affected by tuberculosis under treatment, including 1.5 million of persons with drug-resistant TB, and including about 115,000 children. Here, you can see how we've progressed in this goal by 2021. As you can see, by the end of 2021, we had only achieved 43% of the goal. That is less than half the goal. And you can see that percentage is even lower if you had the goal we had set for ourselves for the treatment of drug-resistant TB in children. And now, how do we stand in the Americas region? The dark columns are the estimate of WHO of people who develop tuberculosis resistant to rapamycin and multi-drug resistant. You see how that number increased in 2021 as we saw an increase in the general overall cases of tuberculosis due to the impact of the COVID pandemic. In fact, by 2021, we expected to have in the region 12,000 cases of drug-resistant tuberculosis. And in the red columns, you can see how many of those estimated cases expected to have drug-resistant tuberculosis were diagnosed and confirmed cases in the region. And in light blue is the number of cases that started treatment. You can see that almost 95% of the cases that were diagnosed did receive treatment. But you can see there is still a big gap between the estimated number and the actual number that was notified, diagnosed, and treated in the region. The gap is almost 7,000 persons, which represents about 60% of the estimated persons who were not diagnosed, not treated, and therefore remained in the community, favoring the transmission of drug-resistant dose strains and with a higher risk of dying from this disease. Next slide. Something that we know that is limiting the diagnosis of drug-resistant diagnosis is that we're doing very few drug sensitivity tests. In the case of rifampicin, the OMS recommends access to universal tests of drug-resistant sensitivity. All cases should have a sensitivity test, at least for rifampicin. Here you can see the percentage of new cases, and in blue, those that had been treated before, who were tested for resistance to rifampicin over the years. So you can see it has been increasing, but very slowly. And by 2021, 62% of the cases treated before and 55% of the new cases were given that test. But we still need a big effort to reach the goal of 100% testing for rifampicin resistant. We all know that cases that have resistance to rifampicin should receive a sensitivity test for the second line drugs. Specifically, you can see here the lowest coverage we still have in the region. For cases of people who have rifampicin drug resistance who did get a sensitivity test to fluoroquinolones. You can see here that as a result of the impact of the pandemic, this coverage dropped in the last few years. So this is a major barrier in diagnosing diagnosis of DRTB and XRTB. Something we must do is use rapid molecular tests as the first test to diagnose tuberculosis. You know that the most used technique is the expert that allows us to diagnose resistance to rifampicin, but we also have cartridges that are available that allow us to diagnose the resistance to cernicide and fluoroquinolone. And with this equipment, in the same day, we can diagnose tuberculosis resistance to rifampicin, MRD, and PRMRD. That was not achievable a few years ago. Here you can see the percentage of persons diagnosed with tuberculosis that have a molecular test. It's still a low percentage. It should be higher than 90%, and we're only at 30% in the region, which is below the value we have set for our global goals. So this is a strong appeal to have countries update their diagnostic methods for tuberculosis. Here you see the results of the treatment in the last few years. In the left, you see the treatment results for people who had MDR and XDR in the last few years. We have available data. The success of treatment is green, far from the goal of 90% that we want to have in treatment. And highlight the high mortality in red and the loss of follow-up in dark brown or yellow. There has been improvement of the years, 3 percentage points in the last few years for MDR and more marked for XDR cases, almost 70% increase from 2015 to 2019, perhaps due to the more effective systems that have been used in the last few years for XDR. And we know that due to this interventions that some countries such as Peru have adopted, and implemented that is focusing on care, that focuses on this person specifically, particularly in XDR cases. The good news is that fortunately we have better treatment systems available, recommended by WHO. And you know that by the end of last year, WHO updated evidence, the guidelines for the treatment of drug-resistant tuberculosis, and we recommended the use and program of shorter regimens that are completely oral. We have a 6-month for TBRR, MDR, and BPAL-M for those who are susceptible, which is a significant change, which could significantly increase our success rates, our cure rates, due to greater efficacy, but also to greater access that can be provided because it's of a lower cost and because of the significant improvement in the quality of life of the persons affected by tuberculosis. That's what we will be talking about today. And I wanted to say that the major problem is, of course, is that it takes a lot of time from when we came up with these recommendations that were evidence-based until we actually have been able to bring about an extensive implementation in the countries. That's why together WHO and civil society, technical donors, and other interested parties, other stakeholders published on the World Tuberculosis Day this call to action to speed up the introduction of these new regimens of shortened 6-month treatment, and as part of the comprehensive care measures. Specifically, with this call to action, what we urge governments to do is undertake the following measures to support all partners. We urge them to increase their access to rapid diagnostic tests and sensitivity tests, not only for fluoroquinolones, but the other medicines we use, such as bedaquiline, petomaniad, and linezolid, and that they update their national policies to include these new recommendations, new regimens, and that they initiate and guarantee the continuous provision and accessible provision of these new medications for these shortened systems, that they update their national regulatory policies to allow for the importation of these new medications and diagnostic tests, which we know are a process that often takes time in countries, that they also ensure the training of healthcare staff, as well as community agents, support groups, patients, activists in TB, so that everyone is prepared for the quick implementation of these systems. And we've also been told that we should learn from the experience of the first countries that have implemented these systems. We know that in the region, there are already several countries that have been implementing it, thanks to the operational research done in the last few years with shorts. We know that, for instance, Dominican Republic, Colombia, Peru, El Salvador have experience with these systems. Also, the importance of allocating sufficient resources and the importance of intensifying the effort of advocacy programs with the general public, but also decision makers, so as to speed up the implementation of these systems. And also ensure joint work with the community and civil society. It also talks about the importance of the use and implementation of digital tools to ensure adherence and follow-up of the treatment, and that the country should strengthen their drug surveillance national systems to ensure quick detection and management. And finally, to continue investing and innovating so that we can continue to having new, more efficient treatment options for treating the disease. So as we said, from the perspective of WHO, together with the Green Light Committee, we would like to initiate these virtual sessions to present the evidence, discuss the new guidelines, the WHO operational manuals for the treatment of drug-resistant tuberculosis, but also for sensitive tuberculosis, and to provide support to treatment and care. We would like to share some of the experiences of the countries in the region in using the treatment community support, the social protection systems for people who are affected, and also review all the very important recommendations for diagnosis. And we would like to organize a special session on the management on DRTB in children, the whole question of drug surveillance, and the supply chain, and the development of programs to introduce these systems together with the strategic fund of the Pan American Health Organization. So here we have this first session where we will look at BPAL specifically. For this, we have Dr. Rafael Añado, the chairman of the Regional Green Light Committee, and Dr. Alberto Mendoza, vice president of the Green Light Committee, the Regional One. And we have special guests, our colleagues from the University of Milan, who will be presenting the research they have been doing in the Unite for TB consortium. They will tell us the progress they've made in the clinical trials that would allow us to have available even shorter systems for the treatment of TB, as well as the treatment of sensitive TB. Without any further ado, I now hope you enjoy the session. Please do not hesitate to ask any questions, and any question or comment you have can be done through the Q&A section at the very bottom of the screen. But also, please don't hesitate to contact us through the country offices if you have a very specific question on the treatment we are going to be presenting now. And I'd also like to appeal to you to please help us accelerate the introduction of these regimens in the region. Thank you very much.
Thank you, Pedro, for your very important presentation.
You can select the language at the bottom of the screen in the interpretation section, please. Thank you. Bien, con esto vamos a dar paso a nuestro segundo tema que tenemos en la agenda del día de hoy.
We're going to move on to the next point that we have on our agenda, and I want to welcome our colleagues from the University of Milan, to whom we will now yield the floor. Pier Paolo.
Yes, thank you very much. Let me just share the screen and go to the first slide of our presentation. Do you see the screen?
Yes, go ahead.
Yes, very good. So thank you very much for this opportunity. We really appreciate that. And this is a continuation of something that we started last year with WHO regional office there in Washington. We are going to present about the Unite for TB project, and specifically an update of the first 2 years implementation of a project. And this is through with myself, Pier Paolo De Colombani, and then is also Simone Villa and Giuliano Gargioni online, and Mario Reviglione, Professor Mario Reviglione, will also join us very soon. He is now busy with other commitments of the University of Milan. The Unite for TB project is part of the Innovative Medicine Initiative 2 of the European Union, who is putting half of the total budget of 185 million euros distributed in 7 years project that started in June 2 years ago. The other half of the budget is provided by the European Federation of Pharmaceutical Industries and associations and associated partners. There are 30 participants in this consortium. You see in blue color those public, you see prestigious universities and research institutions. There are also a private part that you can see in red: Janssen Pharmaceutical, GlaxoSmithKline, Otsuka, the German Institute of Infectious Diseases, and the University of Munich. Most of these partners are located in the European Union. There are also 3 in the United States, TB Alliance, CPAF, and the University of California, San Francisco, and the one in South Africa, TASC. The objectives of the project are several. The first is to accelerate and improve the clinical evaluation of new drugs and new drug combinations, and this is to treat drug susceptible and drug-resistant tuberculosis. The second objective is to establish a global network to implement a global network of sites to implement phase 2A, B, and C clinical trials. A third objective is to integrate the adaptive trial design with biomarkers of treatment success. Other objectives to employ pharmacokinetic, pharmacodynamic models, artificial intelligence, machine learning techniques, eventually to set new standards for the development of new drug and drugs combination. And this through building a data management sharing platform and act as a global forum in order to put together key stakeholders on tuberculosis and also collaboration, dialogue, coordination among different research consortia. So we are talking of a project that is started 2 years ago and wants to develop new drugs and new drug combinations beyond the BPAL and BPAL-M that is the main subject of this webinar. In terms of so far major achievements, you see that based on the different objectives, there are two new chemical entities that have been that will be differently combined in different regimen options for clinical trials 2B and C. And 2 clinical trials that I'm going to describe later are expected to start in September 2023, this year. In terms of global network of clinical trial sites, there is a preliminary list of 15 of these sites distributed in 4 WHO regions. There is a phase 2B and C design and protocol that are ready and which already included some European EMA inputs, and phase 2A design that is under final discussion with another consortia of the European Union that is named ERA40B. And then there are major biomarkers that have been shortlisted. Pharmacokinetic, pharmacodynamic model, artificial intelligence models are being optimized, and digital address technology has been selected. In terms of new approaches in developing new drugs and new drug combination, we should mention the stakeholder analysis that is considered the first round of stakeholder engagement has been completed last year, and I'm going to present the results. There are some delays in building the data management sharing platform. There is already a collaboration established with other research consortia like PAN-TB, ERA40B, and EU PEARL, and other consortia are also under a dialogue and connection. And as I mentioned before, the first achievement that we would like to report to you is that our team, our university was directly involved. That was a stakeholder analysis. So last year, between March and August, we contacted the 56 major global TB stakeholders, and we managed to interview 50 of them. You see the names in these slides. There are policymakers makers and government agencies, including WHO, headquarters and regional offices, the European Communicable Disease and US CDC. There are a number of national TB programs. There are government donors, other international donors. There are major NGOs, national like Black Bangladesh Dopasi Foundation in Pakistan, and other international and the research institutes. And from the stakeholders analysis, we would like to report the 10 top recommendations that we reported to the senior management of the United for TB project. The first is that to ensure that the clinical trials outcomes meet the WHO requirements, to develop policies and guidelines, and specifically not only adding to the clinical outcomes that the United for TB initially consider, like efficiency, duration, and safety, also some programmatic needs that are so important for the national TB programs, like the cost effectiveness and the cost utility of new regimens, and what are the target populations, if these regimens are going to cover all group of high risk of tuberculosis, like, for example, the children that you also mentioned in the previous presentation. And the formulation and the shelf life of the drugs that are so important for the procurement and supply management of these drugs. And then also important aspect of our requirements that WHO ask are the burden of monitoring the treatment and the pill burden and the forgiveness, the possibility to miss some of the doses of the treatment. This is a exquisite point of view and of people that are suffering with tuberculosis. Second recommendation is in a way linked to the first one, that is to start already now to discuss about the future cost of new regimens, thinking of need of ensure equitable access of new treatments to all, in all settings, and more especially to ensure that treatments and also all tests, laboratory and other tests to monitor the treatment should be made affordable, especially for low and middle income countries. Third recommendation is to develop, think already how to combine in a fixed dose these new regimens, and this not only to simplify the procurement and supply management system, but also to prevent the development of resistance to the new drugs. Fourth recommendation is the important to coordinate among the different research consortia. And the fifth recommendation is considering to engage international stakeholders to facilitate the dialogue among these research consortia. Sixth recommendation, 7 and 8 are very of major interest for the national TB programs that flag the importance to carefully select the clinical trial sites in order to ensure that are all different risk group of TB risk group of populations are are included in these clinical trials, and then to involve in national TB programs to ensure the proper selection of the site, and also to build some local research capacity, and then also together with the national TB programs to identify bottlenecks, some of for the rapid uptake of new regimens, some of them that have been made evident in uptake in the BPAL new regimen. Ninth recommendation is to advocate for adequate and stable funding of future after the Unite for TB project that is covering the phase 2 clinical trials. So we are thinking of ensuring the funding for the phase 3 clinical trial that would be most probably necessary. And the last recommendation is to ensure information, sharing information among the different stakeholders, and this is also the meeting of today. Other important achievement or under the United for TB project is the 2 incoming clinical trials. The first one named Paradigm for TB, and the second one that is BTZ-043 Decision. The first Paradigm for TB clinical trial is about the evaluation of multiple regimens and the multiple duration of these regimens, containing one or both GSK 656 and BTZ-043, the 2 new chemical entities that I mentioned before, and this in adult patients with rifampicin susceptible pulmonary TB. The GSK 656 is a RNA synthetase inhibitor that is impacting of the protein synthesis and is made by GlaxoSmithKline. And the BTZ-043 is DPR-E1 inhibitor that is impacting on the synthesis of the cell wall, and is being developed by the German Center for Infection Research of the University of Munich. And this BTZ-043 decision is a clinical trial that is going to explore the different duration of a combination of this new chemical entity with bedaquiline and delamide, again in adult patients with rifampicin susceptible pulmonary TB. More in detail, let's start from the second clinical trial that is a little bit more simple. Is a dose optimization phase 2b clinical trial that will evaluate the safety, pharmacokinetic, and exposure-response relationship of different doses of BTZ-043, and you see against reference treatment composed by bedaquiline, delamide, and moxifloxacin of 16 weeks will be bedaquiline, delamide with BTZ-043 in different doses, 500 milligrams, 1,000 milligrams, 1,500 milligrams. The clinical trials selected has been are in South Africa and in Tanzania, and is going to this clinical trial going to start in September, October 2023 with the first with the enrollment of the first patients to reach a total of 90 patients. The duration of this clinical trials will be for each participant of 24 weeks, so 16 weeks of treatment and other the rest of weeks of follow-up, and the total trial from the first patient enrolled to the last patient evaluated is of 1 year. The paradigm for TB, the first a little bit more complicated clinical test that is on the pipeline is a randomized, open-label, multi-center, multi-arm, multi-stage phase 2 platform clinical trial with two major objectives. One is to identify the best in terms of efficacy and safety 16 weeks regimens compared with the standard of care of 24 weeks standard TB treatment. And the second objective is to identify the optimal duration of the regimens. 16 weeks regimen have been selected during the phase 2B. And there are also a few sub-study objectives. And here is an overview of this clinical trial. You see that the reference treatment, standard of care, isoniazid rifampicin, pyrazinamide, tambotol, intensive phase with a continuation phase of isoniazid rifampicin for a total of 6 months will be compared with a different combination of betaquolin, delanamide, and moxifloxacin with GSK 656 and BTZ 043, all of them with a duration of 16 weeks. And those treatments that will pass will shown effective and safety will move to the phase 2C and the duration will be between 8 to 16 weeks for a total study population of 44 for each 44 patients. I mentioned the 15 clinical trial sites that has been preliminarily identified. This is a list that is still flexible in terms that there are still some further evaluations ongoing. In your region, you see that there are 4 sites that they've been basically being approved for further negotiation. 4 are in Brazil, 3 in Rio de Janeiro, 1 in Manaus, while the possibility to enroll also an additional clinical trials in Peru, in Lima, is under pending for major elements of clarification. More information about the Unite for TB project you can see in the website, LinkedIn, Twitter. There are from the website you can download also newsletters, and you can also participate in different webinars that are periodically organized. And this was the last slide. I try to be fast and speak on the time that is being given. Thank you.
Muchas gracias, Pier Paolo, por.
Thank you so much, Pier Paolo, for your presentation. The studies and progress made is very important to have everyone be familiar with in our search for the best solution. I'd like to ask participants to ask their questions in the Q&A section and put in any questions you have. At the moment, there is no question for Pier Paolo, but you can continue writing during the rest of the session. We invite you to do so, and then we will answer each one of them as you enter them, or we can do so later on, but preferably we'd like to respond during the session. For the moment, Pier Paolo, I don't see any questions.
Okay, I will start.
well-
We are in standby, and Mario also will join us soon.
Okay.
Perdón, Francisco. Hola. Hay dos preguntas.
Francisco, there are two questions at the moment. Dr. Pier Paolo, the first is, how would you apply artificial intelligence to this process?
Yes, artificial is a very nice question, and let me see if I have one slide that I can show you. Yes, I share again my screen. I have some additional slides that I can show you. Yes. So, sorry. Yeah. So, basically, the artificial intelligence and is used in enhancing the work of others. I mentioned about 30 institutes partners in the consortium, and these partners are grouped in work packages. So WP, and so the artificial intelligence is there to facilitate the work of the different work packages. So we are talking of the design of a clinical trials, work package 2, the pharmacology, and the work package 3, the working microbiology, work package 6, the identification of biomarkers, work package 7, adherence to treatment, work package 9, and data sharing, work package 10. And so is an ongoing process work, the work on artificial intelligence. And you see that has been used to prioritize the treatment regimens that are going to be using the clinical trials. Has been used to identify the biomarkers candidates been developed to support the pharmacometrics analysis and to support the adaptive clinical trial design. And more is going to be used in during the years of the project. What I mentioned that are also shown in the slide in red are just some specific milestones that are included in the project. And on the bottom of the slide, you see that artificial intelligence is basically to make faster and possible something that before was extremely difficult. That was to basically put the whole genome sequencing of together of more than 65,000 MTB collected, and you see graphically what is the process.
Okay, gracias, Dr.
I'm not an
Tenemos-
expert on artificial intelligence, so I try to word to respond to your question.
Creo que sí. En todo caso, tenemos otras dos preguntas. Queremos hacerlas y
We
tratar
have
de...
two other questions. Let's try to ask them and see very specific with the answer. The first question is, when you mention a combination of drugs, is that for the new treatment regimes or are you talking about the new drugs that are under study?
The combination is a combination of new entities, chemical entities with already known drugs. And so basically you see the two new chemical entities that I mentioned before, GSK 656 and BTZ 043, that are combined with already known drugs. And so there are basically three different backbones. The one is the bedaquiline delamanid backbone, so two anchor drugs, these two, plus in addition one selected among linezolid and moxifloxacin and parazenamide. And these are also recommended for the rifampicin-resistant tuberculosis. So they actually, even if the clinical trials have been designed, are considering to enroll adult patients with rifampicin susceptible pulmonary tuberculosis. The idea is during the 7 years project to come out with a treatment that is not only shorter than the DPAL, but also a sort of universal treatment that will can be used for either susceptible or drug-resistant tuberculosis.
Okay, thank you.
There is another two backbones that you can see in these slides.
Oh, okay, yes. Thank you, Dr. Pierpaolo. And finally, is another question about what is the success rate with the combination BDT, and how do you manage the side effects of the new combination?
Well, this is something that we will know when the trials will be implemented.
Uh-huh.
So the trials are not started yet. As I mentioned, the first patient will be enrolled September, October this year.
Okay, thank you so much. Thank you, doctor.
Thank you.
Muchas gracias, doctor Pierpaolo.
Thank you very much, Dr. Paulo, for your response. And I would like to thank the guests and invite you to continue making your questions, and we'll continue to answer them through the rest of the time. The next presentation has to do with the evidence WHO has used for updating its guidelines in the treatment of tuberculosis. This presentation will be done by the president of the Green Light committees, Dr. Lanyard. Go ahead, sir. Thank you, Francisco. Good morning to everyone. Since as Francisco did, I'll try to show you in 25 minutes the evidence used by WHO to use its treatment guidelines. I have no conflict of interest. And before I start speaking about the treatments, I'd like to remind all participants that we need to do lab tests to determine sensitivity or resistance. We require that all patients that are diagnosed to have a test for rifampicin resistance. When our rifampicin resistance exists, then there will be a molecular test for fluoroquinolones, which today with a new expert platform can be obtained in a couple of hours. And finally, if you already have a pre-XDR patient, then all these cases will require in the lab, which could be a regional or national reference lab, it will require a test for dilacaminide, BDQ, CFC, and LZD, because we have molecular tests for these drugs. So it's vital. You can't work blindly and establish a regimen without having the sensitivity test baseline. I will talk specifically about drug-resistant TB to RR, MDR, and pre-XDR. Two recent studies that address this problem, the Xenix study and the TB Practical. What the Xenix wanted to assess was oral regimens of 6 months based on a combination of bilecoline, pretomanide, to determine the appropriate doses of linezolid. And then the TB practical was a assessment of a new oral regimen of 6 months with bedaquiline, pretramanid, linezolid. That's why it's called BPAL. But before I mention this, I'd like to mention the NICS TB study, the first BPAL, which assessed the safety, pharmacokinetic safety of a completely oral treatment with pretracamin and linezolid. These were patients of 14 and above in 3 South African centers. The initial dose of linezolid at that time was 1,200 milligrams per day. There are only 109 patients who participated in the study, and 71 cases, 65% were classified in XDR with the old classification. Today they would be called pre-XDR. 19, which was 17%, were classified as TB-MDR that had not responded to treatment. And 19, that is 17%, were classified as TD-MDR to whom the treatment had been suspended because of side effects. 16 patients, that is 14, almost 15%, had a negative test before beginning the trial. Now, how did the patients fare? Well, those that were classified XDR back then, which really were resistant to quinolone, rifampicin, and some injectable, perhaps 89% success. In the MDR, 92%, and overall 90%. The problem they had was due to the high doses of linezolid. Was 57% of the 109 patients had a grade 3 or 4 negative effect that are serious adverse effects. That was the problem with linezolid during the treatment. 88 patients showed a peripheric neuropathy, myelosuppression in 52 patients, 48%, and total 37% only completed 26 weeks of treatment with linezolid without interruption, although there may have been a drug reduction, and only 15% completed this 26 weeks using 1,200 milligrams of linezolid. That's why we did the Xenex to see if it was possible to reduce the dose of linezolid. The Xenex study, as I said, evaluated if it was possible to keep the efficacy of BPAL and yet reduce the toxicity of linezolid. They did a study of 1,200 milligrams for 26 weeks, same as NICS. Another study with 1,200 milligrams, but only for 9 weeks. Another group with 600 milligrams for 26 weeks. And finally, another group of 600 milligrams of linezolid for 9 weeks. The treatment was not supervised, and the linezolid doses could be reduced in a scaled down way from 1,200 to 600 to 300, even to 0, if there were a side effect. We always used a placebo to keep this a blind study. In Xenex, we included 181 patients 14 years older and under 35 who had pre-XDR and TB-MDR that had not responded to treatment, or in the case of suspension of the regimen because of side effects. And as I said, they used the old definition of TB-XDR. Bedaquiline was used 200 milligrams a day for 8 weeks, followed by 100 milligrams per day for 18 weeks. And we then made sure there was no change in the dose that is usually used in order to encourage adherence and facilitate the administration of treatment. Of the 181 participants that participated randomly, 41% had classification XDR, 47% pre-XDR, and 11% had tuberculosis MDR. The 4 groups had 45 or 46 patients totally. And 155 of the 181, that is 85%, completed the study. The main goal, the primary goal of the study was to the level of bacteriological failure, relapse, or clinical failure during the follow-up up to 26 weeks after the end of the treatment. With a very interesting result, not said a different way, 9 participants had phenotypical initial resistance to bedaquiline, 2 additionally had resistance to linezolid, and another had resistance to pretomanid, of which 6 of the 9 were cured, even though they had resistance to 2 of the 3 drugs. 2 additional participants had basal isolation because of monoresistance to pretomanid, and they also were cured. The patients were followed by video dot. They were followed for a minimum of 78 weeks after having completed the treatment. And something similar to we saw in NICS, 50% of the patients had a negative bacilloscope at the beginning of the study. In 95%, we didn't know if they had diabetes. We did not check for that. And 1 out of every 5 patients were people living with HIV. Of the regimens I mentioned, the one that worked best, balancing in efficacy, neuropathy, and myelosuppression, was BIPAL with 600 milligrams for 26 weeks. Efficacy 91%, neuropathy 24%, and myelosuppression 13%. That's the doses, therefore, we recommend 600 milligrams of linezolid for 26 weeks. The studies of the Zenix studies allow us to identify the dose of linezolid that offers the best balance in terms of efficacy and safety in patients over the age of 14. And the evidence suggestion is 600 milligrams per day. And this doses must be kept throughout an entire regimen to ensure efficacy, although it is possible to reduce the dose in case of toxicity or intolerance. In the other study, practical, these are the acronym for a pragmatic study with a more effective, concise, and less toxic regimen. The subjects were 15 older in South Africa and Uzbekistan. Regimen number 1 was bedaquiline, petomalid, MFX, and LZD. 600 milligrams for 16 weeks, and then 300 milligrams for 8 weeks. Regimen 2, they changed MFX for SCFZ. The third regimen was, and finally, the last group was patients that had received standard treatments suggested by WHO for 9 to 20 months.
The usual inclusion criteria include older than 15 years of age, RRTB, the HIV, or resistant to fluoroquinolones. It did not matter. Some of the exclusion criteria included a pregnancy 3 times the upper limit of the normal range, QTC greater than 450 milliseconds, structural cardiopathy, and others. This study was divided in 2 parts. We started with the 4 regimens that we saw first, and they selected the best of the 3 experimental regimens, and they set aside 1 as a control. This was equivalent to a phase 2, and this was equivalent to a phase 3. This trial was not designed to compare the effectiveness between the regimens. Now, why did we choose BPAL-M? Well, the reason was that it achieved a higher percentage of culture conversion over 8 weeks. The BPAL-M converted patients at 8 weeks on the order of 77% compared to 67% with BPAL-C and 45% with BPAL. So the decision was made to stay with this regimen and compare it with the standard. In terms of the efficiency or effectiveness evaluation criteria, there were a number of issues such as failure, death, or no follow-up. Now, how did the practical work? So when we talk about everything that met with the protocol requirements, we saw pretty decent rates for BPAL-M compared to the standard care group at 88%. When we talked about the modified intention to treat population, we see the differences in the percentages. And in the intention to treat population with BPAL-M, the success rate was on the order shown here on the slide. So BPAL-M did exceed the standard treatment for the control group. In terms of adverse effects, they were not as evident as with the BPAL with the high levels of linezolid. we had 60% of patients with one event in the standard group, whereas it was 25 for BPAL-M group. The evidence suggests that the BPAL-M regimen over 6 months can be used programmatically in RRTB or MDR-TB patients without prior exposure to these medications instead of the 9-month regimen. Once we had these two trials, what was it that the WHO did with the information? In 2021, the WHO issued a public call for data, asking the public to provide data so that we could conduct a comparative analysis along with the standard. So we were able to compare the regimens for 6 to 9 months. These cohorts that involved more than 5,100 patients received treatment in accordance with the directives of the WHO related to DRTB in 2020 with bedaquiline and linezolid over a period of 6 to 24 months. We developed a number of PICO questions to address any uncertainties. The database included patients that used one of the following regimens: oral regimen from 6 to 12 months with bedaquiline and linezolid, the 2019 9 to 12 month regimen issued by the WHO, completely oral that contains bedaquiline in the combination, as well as the completely oral WHO 2018 regimen. So how did these perform when we compared the BPAL for Xenex with the shortened 9-month treatment with ethionamide or linezolid for 2 months or 12 months? The Xenex showed a higher success rate for treatment with 45% more, lower mortality rates, 19% less, and follow-up losses on the order of 11%. And when we talk about MDR-TB cases, when we compared Xenex with the longer treatment, up to 18 or greater than 18 months, the BPAL again showed a higher success rate with 32% more, less failure and recurrence, 29%, lower mortality, 11% less, though there were more adverse effects observed. Lastly, when we compared these regimens with patients with resistance to fluoroquinolones, BPAL Xenex had a higher success rate, lower failures and recurrence, lower mortality, lower follow-up losses, though with more adverse effects and amplification of resistance. So when we ask the questions about how much this is all going to cost in terms of changing the treatment protocols from the older ones to the newly adopted ones, the PAHO TB team made a calculation and they found that the BPAL without the moxifloxacin has a cost of approximately $611 to $618. These are GDF costs through the PAHO Strategic Fund. BPAL-M is slightly more expensive, approximately $20 to $30 more than the moxifloxacin, oscillating between $638 to $640. Of the oral regimens for 9 months with the different drugs over that period, the cost was $557. So we're talking about a difference of $60 to $80 less. And in the 18-month regimen, $771, which is more expensive than both the BPAL and the BPAL-M regimen. So given the drop in the costs associated with this strategic approach, then the cost difference then is minimal. In conclusion, this is the evidence that the recommendations are based on, the recommendations issued by WHO for the treatment of RR-MDR-TB with BPAL-M and the treatment for pre-XDR-TB with BPAL. Thank you very much for your attention.
Muchas gracias, Rafael, por esta presentación.
Thank you very much, Rafael, for that very extensive and complete presentation. This allows us to address any concerns that we may have about the new treatments. It's also important for us to understand what the latest evidence is that led to the WHO issuing these new recommendations. I also wanted to mention that the costs that Rafael showed us in his slide are the cost of medications, both for the BPAL and BPAL-M, as well as the other regimens, but this cost does not include shipping costs because that depends entirely on the different countries that have different shipping costs associated with them. So the comparison is based on the cost that relates only to the medication or the drug itself. We'd like to encourage everyone to continue sending us your questions through the Q&A room. Now we're going to open the floor for the next presentation, after which we will set aside some time so that our panelists can have some time to answer questions or listen to comments from all of our participants. So you can continue to submit your questions through the Q&A room. The next topic, which will be led by the Vice President of the Green Light Committee, Dr. Alberto Mendoza, relates to specifically the use of 6-month regimens with BPAL-M and BPAL compared to the oral regimen projected over 9 months, and how these regimens are managed, who can receive these protocols and who cannot. So we're going to yield the floor to Dr. Alberto Mendoza so that he can discuss this part of the session. Go ahead, sir. Thank you very much, Francisco, and thank you to Pajo for the invitation to take part in this session. Can you confirm that you can see my presentation? Yes, we can. Very well. Over the next 30 minutes, we're going to be talking about program issues related to these two regimens that are being recommended by the WHO that were issued for 2022. I just wanted to mention that I have no conflict of interest with regard to this topic, and the objective of the presentation is to review the compliance indications, restriction, or program implementation issues related to the shortened oral regimens supported by WHO in its most recent update. I wanted to say that in the TB or drug-resistant TB guidelines issued by the WHO, they highlight the need to have reliable and guaranteed quality access to these elements, and WHO recommends the use of rapid molecular testing, approved rapid molecular testing as the initial test to be able to detect TB and other drug-resistant TB before initiating treatment for all patients. So the WHO recommends very strongly that approved rapid molecular testing be the first step in the diagnosis of the type of TB in place, and that this needs to be applied to all patients prior to initiating any treatment protocol. The recommendation is for rapid molecular testings, especially as it relates to rifampicin and INH and FQX. It's mandatory to do testing for RIF for all patients and FQX for all RRTB cases. And we can see that we need to determine whether there's any resistance to the fluoroquinolones. Now, the absence of sensitivity does not eliminate the need for any of the new regimens. Now, there's a great deal of work yet to be done. The previous national data related to DRTB prevalence in high-risk groups need to be used as a guide for the development of algorithms. And given that we've seen some updates for treatment protocols for resistant TB, we can see all of the acronyms that we will need to take into account in the technical documentation to be able to standardize everything that we do. DRTB, which is drug-resistant TB, the TB that is resistant to isoniazid and sensitive to rifampicin, the RRTB, which is rifampicin-resistant TB, MDR-TB, RRTB and MDR-TB, pre-XDR-TB, which is tuberculosis that are resistant to rifampicin and could be resistant to isoniazid, and is also resistant to at least one fluoroquinolone. And finally, we have XDR-TB, which shows resistance to rifampicin and could also be resistant to other drugs. As Rafael mentioned, we don't have any current rapid molecular testings for all of these drugs that are listed here, bedaquiline, CFCs, linezolid, and others. The WHO is currently evaluating sequencing testing for new generation products. This will allow us to expand the current portfolio of testing that we have, especially allow us to build on the existing HIV testing. Now, we do have programs that are already exist for some of these elements and agents, such as bedaquiline and fluoroquinolones and linezolid and rifampicin. We need to try to expand the use of these existing methods. It's also important to highlight some things that really stand out in the guidelines. The lack of the capacity to conduct the susceptibility or sensitivity testing in all patients should not be an obstacle to initiate an MDR-TB treatment regimen that could save their lives. We also need to be able to consider a context of potential risk of prescribing an inefficient treatment and actually worsen the resistance. So we need to estimate the efficiency probability of the regimen based on the medical history, medication history, resistance pattern, or the contact or index case, and most recent resistance prevalence data. So we need to be able to address a particular group of drugs and come up with the most adequate prescribed treatment. And so we need to combine these into a proper balance of drugs and quality of service and treatment. Clearly, we need to monitor patients very closely. We need to continuously monitor their condition clinically and address the pharmacovigilance elements in play. If the response to the treatment is deficient, we need to consider the possibility that there may be undiagnosed pharmacoresistance. There may be the coexistence of sensitive microorganisms that are resistant in the same patient, and we need to consider alternative explanations. Not everything can be classified as resistance. This could include deficient adherence or erratic adherence to treatment, the improper absorption of medications, education, counseling, or support that are deemed to be deficient. Now, many times we can have confusion in terms of resistance or some other condition that is affecting the patient. Some key factors that are proposed by WHO to be able to select the best DR-TB treatment protocol includes the profile of the pharmacoresistance. We also need to consider the prior exposure to anti-TB medication and assess any cross-resistance, for example, bedaquiline and CFC, PTM and DLM. Additionally, we need to consider the pharmacoresistance profile of the contacts for the patient, whether it's the mother that may have had MDR-TB prior to this patient's condition and what have you. The age of the patient, we need to see that the clinical studies are based primarily on patients 14 years of age or older. So we need to focus primarily on the current evidence. Any extension for the pulmonary TB, many of the prior regimens excluded some patients for some specific criteria. So we need to be very careful with the particular situation of each patient to ensure that we cover all our bases there. Additionally, we have to localize the various extrapulmonary TB elements that could be in place. The treatment protocols recommended by WHO for TB resistance include the standardized and the individualized regimen. Among these, the standardized regimen is the one that has the best impact in the public health arena because it's the fixed regimen that is based on the resistance pattern as well as other specific indicators. And it's also something that can be extended depending on the treatment protocol, any suspension of the treatment, or any other minor consideration. Whereas the individualized regimen is based in accordance with peculiar characteristics exhibited by each patient, which is the result of susceptibility testing and other tests. And therefore, this classification is important because we've already talked about the resistance pattern, the regimens recommended by WHO, and this is for TB susceptibility, for drugs, TBHR. When we talk about RR-MDR TB, we have 6-month standardized BPEL-M regimen, 4 to 6 months with totally oral treatment. Then we also have longer regimens that can extend out to 18 to 20 months. Now, for pre-XDR and XDR TB, we have typically longer treatment periods that are standard, that can be standardized, but for individualized care, we cannot use the standard treatment protocol. So let's focus on these regimens, particularly the BPEL-M and the BPEL regimens. The recommendation by the WHO suggests the use of a 6-month treatment protocol that includes bedaquiline, pretomanate, linezolid, moxifloxacin, instead or in lieu of the 9-month or more extensive 18-month regimens used with RR-MDR patients.
Even though the evidence presented by the countries, it corresponds to 2 clinical trials with a very small patient number. And so the recommendation is still conditional. This is the regimen. Bedaquiline of 100 milligram tablets can be given either 400 milligrams daily for 2 weeks, and then you switch to 200 milligrams 3 times per week, or you can give it 200 milligrams daily for 8 weeks, a little longer, and then 100 milligrams daily. The advantage is that you give everything only once a day. That's what's most important. Pretomanate, 200 milligrams once daily, linezolid, 600 milligrams once daily, and moxifloxacin, 400 milligrams once per day. There is no evidence yet to do a BPEL that contains dilamide instead of pretomanate, or to switch LSFX to MFX and reduce it to 300 milligrams, but only after week 9. Only then could we reduce it, but we don't recommend reducing it before that. So what are our observations with this regimen? First, we strongly recommend BS for fluoroquinolones and people who have resistance to rifampicin. If I don't have a quick test, I can send out the phenotypic test, but begin BPALM, and then the results can guide us on our decision. So whether I suspend MFX and continue BPAL only, or whether I add MFX and keep it. To detect the resistance to phenoquinolone, what we recommend is rapid molecular tests, preferably over cultures. Why? Because they're good tests today, available, reliable molecular tests that are much quicker. In the cases where there is documented resistance to fluoroquinolones and moxifloxacin, BPAL would be a without moxifloxacin, BPAL could be continued, started and continued. Now, in the case of possible resistance to fluoroquinolones, I don't have proof, but I have a patient who's been exposed for more than 4 weeks with no close contact, then it might be best to start BPAL-M until the fluoroquinolone sensitivity test has been done. In the case that you can't have a test for sensitivity to fluoroquinolone, then BPAL-M must be continued for 6 weeks. And if there is high resistance to fluoroquinolone, then I continue with BPAL. If, for instance, a patient who has failed because has had used fluoroquinolone before, and the only source can be the mother or child, then we do a high prevalence XDR test, and we could use BPAL without using MFX. Now, if you do have sensitivity tests for bedaquiline or linezolid, it's very important to begin until results are obtained, because that's a phenotypic test that requires a culture first, and then the results may come in only 2 or 3 weeks. So we should not delay treatment with BPALM. What are the indications for BPALM according to WHO guidelines? People with TBRR, MDR, not in cases with XDR. People with pulmonary TB and all forms of extrapulmonary TB except in central nervous system, osteoarticular, or disseminated mylar. Adolescents and adults of 14 older. Why not less? Because there's no clinical evidence of the safety of retrometade in younger populations. All persons can be taken whether they have HIV or not, whether they're taking retrovirals or not. There would not be any allergy, documented allergy to the drugs in the treatment. No evidence of resistance, confirmed resistance to BDQ, LCD, DLM, and PTM. And patients who have less than 1 month of exposure to BDQ, LZD, PTM, DLM. If the exposure has been more than 1 month, they can continue receiving the treatment as long as resistance has been discarded. No, there's no indication for pregnant women or breastfeeding women. There's limited evidence of safety with PTM. So we strongly recommend contraceptives for women of fertile age. The doses of LSE should be 600 milligrams. Other considerations we have to take into account is that you have to assess the basal cardiopathy. Prolonged basal arrhythmia blockages or cardiomyopathy cause toxicity. And people who had basal cardiac disease have been excluded from treatment. So they're people who have any kind of blockage or arrhythmia, familiar history, etc. Then you have to be very careful and be very careful in the management. If the patient has anemia or other myelodiscrepancies, we have to be careful in using LZD. People who have a low weight are usually excluded from the study because we know that's a very strong marker for prognosis in a patient. Also, we high base transaminase, very careful in using PTM or BDQ because they increase transaminase. And if there is any pre-existing neuropathy, careful with use of LZD. Interaction, the most important, very careful in the use of linezolid when they're using with sertraline and fluotexin. Other drugs that prolong, for instance, clarithromycin, amitriptyline, strophenoticides, and antiarrhythmics. If they have CYP3A4 inhibitors, be very careful in the use of bedaquiline because of antimycotics or macrolides. We can't give BDQ with rifampicin because it affects the metabolism and makes the BDQ drop severely. Myelosuppressive medications like have to be such as pseudobutyn. You have to be careful in using it with LZD. The treatment uses 182 doses for 6 months or 26 weeks, and it's very important to make some modifications. If there's a resistance to metaquinolone, you can continue with BPAL, but you keep this start date of BPALM. In other words, in the 2nd month, I take out fluoroquinolone and start BPAL and start counting the 6 months from that day when you took out the moxifloxacin. BPALM from the beginning for 6 months or 6 weeks. We also recommend extending to 9 months if there's no conversion of the culture at 4 to 6 months. If there's a bad clinical response between 4 to 6 months, and ideally we need to assess the susceptibility to BDQ-LNZ. And if that can't be done, then the patient has to be transferred to an individualized long treatment of 18 months, according to the WHO charts. We should avoid non-taking of a medication to avoid any lost doses. If they lose more than 7 doses in 7 days, they have to recover within a month additionally, up to 7 or 10 months respectively to recover the lost dose. But if the plan was 9 months for a BPALM without M, then you can go up to 10 months to recover. And the temporary suspension of all medication is allowed because of toxicity, and you can reintroduce 14 consecutive days or a maximum of 4 accumulated weeks. You have to recover all the lost doses. If that can't be done because of very severe toxicity, you must consider changing to an individualized regimen. So in what cases will I change to a longer term regime? I may change the dose LNZ to 300 milligrams. But if you need to discontinue LZD because of resistance or toxicity, then you have to discontinue the entire regimen. And if LZD is continued permanently in the first 9 weeks, then you must continue the whole regimen. Now, if I have to do this and yet I only have 8 weeks to end the regimen, I can suspend LZD and keep the other drugs without a problem. That's a recommendation that can be made. If necessary, I could suspend only the last 8 weeks of LZD and continue with the rest of the treatment. And you have to consider replacing BPALM with a long-term scheme if there's interruption for 2 consecutive weeks or more than 14 accumulated weeks caused by toxicity. If their pregnancy occurs while a person is under treatment, we have to discontinue and start with a separate regime. And if after you suspend the regimen and you detect resistance to one of the components, you must continue with except for MFX. In some, for a specific children's population, we cannot use BPALM because there's no evidence so far, but preferably we use the short 9-month oral regime. With HIV, they can use a system independent of the level of CD4. In extensive TBP, it can be used if the regimen is closely monitored and you can have a possible extension of BPAL up to 9 months if there's a bilateral disease. In TB extrapulmonary, we recommend all forms except for the central nervous system, osteoarticular, or dissimilar disease. There's limited information on the penetration of PDQ, PTM, in sensitivity. In pregnancy and breastfeeding, we do not recommend this. Other programs, BPAL must be administered with food and a proper ingestion of water. The medication is more effective with food. You must respond to treatment with bacilloscope and monthly culture. Avoid the use of antacids and calcium supplements that can reduce the absorption of quinolones. Intervention to strengthen adherence by community support, etc., social support. It's important to follow up on the context, assess symptoms, x-rays, rapid molecular tests, and of sputum if there's an abnormal test, and strengthen measures for prevention and control of other infections in the hospital and home. And it's important to follow the patient for 6 to 12 months after he's been released, because this is still conditional. There's not a lot of evidence, and it's possible that when we use massive amounts, we have greater relapse. So we strongly recommend that countries schedule a post-release follow-up 6 to 12 months to follow up the patient. If one important classification is failure. So we use the same categories for conventional systems, but if there is failure, we have redefined what failure means. We say a patient has failed the treatment, there's adverse reaction to the medication, and that obviously would require suspension of BDQ, PTM, or LZD at any time, or at least in the first 9 weeks of LZD. Now, if there is a bacteriological test that assessed that between 4 and 6 months, and if the test for resistance to the drugs that in the treatment, even the baseline, there was a sensitivity. And if there's a positive culture at the end of 4 months, it means it has the bacteria has now resistance to BDQ. Here is everything that has to be assessed: the baseline 2 weeks, monthly, end of treatment, 6 and 12 months post-treatment, the clinical assessment, psychosocial assessment, weight, performance status, screening, peripheral neuropathy, visual acuity and color discrimination, assessment and follow-up adverse effects, and then the sputum smear on a monthly basis, and then X-rays, high electrocardiogram if it's a baseline, if the baseline is high, full blood count, baseline 2 weeks monthly, end of treatment, liver function, electrolytes, creatinine, urea, pregnancy test, HIVs, and BSL, HbA1c. So this is a response for how to develop a protocol for the management. And now we will move to the short oral scheme recommended by WHO for patients who have TB, MDR, and RR. So the 9-month regime is alternate to BPAL, BPAL, where the last regimen did not work. This is the system, and we have 2 variants here: the variant with linezolid and the variant with etionnamide. With linezolid, it says you can replace etionnamide with linezolid for the first 2 months, and that's enough, keeping the second phase the same. Whereas with etionnamide, there is no linezolid, and you place linezolid in the first 4 to 6 months. There are some the regimen that's TB-MDR-RR, and where there is resistance to rifampicin, and it's important to have clear evidence that the patient is not resistant to fluoroquinolones. So there has to be no resistance to BDQ, ZPSC, ETO, and LZD, no prior exposure to FQX, BDX, CVC, or ETO, LZ for more than 1 month, without pulmonary TB or disease, severe pulmonary disease or extrapulmonary. It could occur in women that are, it can be done in pregnant women or breastfeeding, particularly with the LZD, because that is contraindicated in gestation, and adults or children with RR contact with a clinical diagnosis of TB resistance that could be given to children, unlike BPAL-M that cannot be administered. Now, what sensitivity tests have been provided? It should not be administered in PR, XDR patients, nor XDR, or and those have TB, MDR, and their resistance to rifampicin has mutations INH, A, and CAT-G. There you cannot use the short regime. If you identify mutations in gen INH-A, you cannot use the variant with ETO. We recommend a sample for sensitivity before starting the regimen to make the necessary recommendations. In the lack of sensitivity test, the treatment will be based on the probability of efficacy of the drugs, the clinical history, and all the data you have in that region or that country about resistance. Some changes: BDQ can be used up to 6 months, but can be extended to 9. LZD dose is 600 milligrams times 2 for 2 months, but we do not recommend reducing the doses to 300 milligrams because you're only going to be given it for 2 months. So if there is toxicity, we recommend, if toxicity occurs within the 2 months, we recommend going to the etionnamide variant, or protonamide may be used instead of ETO. MFX may be used instead of LFX. Etambutol or pyrazinamide, one can be used, not both. And the decision be to extend the phase from 4 to 6 months, depending on the bacilloscope of sputum at the 4th month. The second phase always is 5 months. On the 6 months, the culture results and bacilloscope should help you determine what other option you must use. In which population can you use the short system? In children, yes. In population of HIV, in extensive TB, no, it cannot be administered. In extrapulmonar, it can be administered in non-complicated formulas, and in pregnancy and breastfeeding, can use the variant with linezolid, but not ETO. The monitoring of the efficacy is equal with the bacilloscope and culture, and obviously you need significant monitoring. I'm going to go through this very quickly because the guideline provides a chart that you can help you monitor the treatment. And finally, the long treatment scheme is individualized. Some countries have said, doctor, our long scheme, is it going to be for all patients? This particular regimen for 18 months? No, that's not the idea. These regimens cannot be standardized. They are still individualized. They follow the hierarchical order of the medication. Here we have patomate that has only been approved for standardized system. BIPAL is not part of this regimen yet because it has not been approved for a universal system, whereas preterminide has been approved for a standard system, and the OMS supports that. So we can use preterminide and other drugs that are not included in BIPAL, who can be used as TB pulmonar, extensive tubular use. But patients with oral system could not use the short one, but they can use the individualized. People who have severe extrapulmonary TB, or patients with RR, MDR with resistance to key drugs in the oral system, failure of previous oral regimens, intolerance to drugs of the oral regimen, children or pregnant women who cannot receive the oral regimen for 9 months, or low IMC. So this is the table that summarizes where you can see the 3 regimens: oral 6 months, oral 9 months, and the longer individualized 18 months, whom it can be given to with MDR, RRTB, pre-XDR, XDR-TB, extensive pulmonary TB, and if they are under the age of 14, and the factors that have to be considered in order to receive the regimen: drug intolerance, treatment history, the patients or family patients, and obviously the costs of the drug. And finally, the 7 messages. TB, drug-resistant TB, is a health crisis globally. There's a new classification of TBDR that we should adopt in all countries. For each type of TB, existing TB that is classified, there is a standardized regimen. And for TB XDR, we have an individualized one. For TBRR, MDR, the preferred treatments in order of recommendation are the BIPAL and BIPAL for the most of the patients that have TBRR, MDR. If that cannot be used, then move to the second one, the short oral one for 9 months. And if not, then the individualized long treatment. Each regimen has its own indications, restrictions, and forms of monitoring and efficacy and safety that you should be familiar with. And the system BIPAL is a valid alternative for TB pre-XDR patients. And the short 9 oral system is preferred for children under the age of 14, pregnant women, and lactating women. It should not be given if there's extensive pulmonary disease. And the long individualized treatment uses drugs ABC and is an alternative when the 6 months short-term system cannot be used, has failed, or there is severe intolerance to the medication, or the patient has an XDR strain from the very outset. That's important. Thank you very much for your attention. Thank you.
Thank you, Francisco. Thank you, Alberto, and to all our panelists for your excellent presentations. Alberto, yours was very comprehensive and detailed regarding the use of these new treatment regimens. I'd like to comment to all of our participants that The guidelines that we've alluded to throughout the course of this session are currently in the process of being translated into Spanish. And in the coming weeks, we expect to have both the guidelines and other associated materials published in Spanish, and all of our Spanish-speaking colleagues will be able to have access to these detailed documents that we've been referring to all morning. Before we go to the Q&A session, we have some time allotted for that. From our regional team, we'd also like to call to all of our clinical colleagues that treat TB patients and also program directors to accelerate in the region the implementation of these new regimens that, as we've seen with very solid evidence in the explanation that our panelists have provided, are susceptible to being implemented in a secure and safe way in each one of our countries. I think that we need to be able to contemplate the costs for these regimens beyond their mere economic value. It's clear that these treatment protocols can save lives. And if we want to look at this from the economic perspective, when we look at this in the long term, clearly the costs in the long term are lower. We have better adherence to the treatment, less need for follow-up services, less involvement of patients to take part in follow-up procedures. And we've seen over time that the overall cost trends to go down. So with this, I'd like to go to some of the comments. I want to thank all of you for your questions, and we've seen that a number of them have already been answered in the Q&A. Thanks to Rafael and other team members that have been answering some of the questions. We could also open the floor on the mic for anyone who chooses to use that. Rafael, I don't know if you wanted to refer to any of the questions that are listed. Well, I don't know if there are any pending ones. Yes, if you like, I can show you which questions are still pending. Perhaps we can read some of the ones that Dr. Rafael has already answered. In case you're having any trouble reading the Q&A, there is one that asks, do you think there's justification for the use of these 18-month treatment regimens? Dr. Rafael mentions that definitely the long-term 18-month treatment is the safety net for all of these patients that, due to their resistance and adverse event profile, cannot receive the shortened treatment protocol. There are many questions, and we will try to read them all, taking into account that we have limited time. Of course, there's another one from Winsome related to the identified resistance, whether or not those treatment protocols were successful. That depends on the BPEL or BPEL-M treatment protocols. Well, using, apologies from the English booth, the audio is intermittent. There's another question by Urmina.
Medication, as many countries have great percentage of TB HIV co-infection. Also, one of the study mentioned that about 20% of their TB cohort had HIV. Could it be possible that the adverse effects be enhanced in those taking ARV? Y la respuesta sería yes, only 5% had HIV. The most troublesome drug for interaction with RBT is rifampin of the BPAL. Bedaquiline has some interaction, but it does not seem to be clinically significant. Wilson nuevamente pregunta si un paciente se le identifica resistencia baja a moxifloxacina, se podría continuar utilizando.
William asks if there's any resistance to moxifloxacin, can it then be replaced by BPAL treatment protocol? In Mexico, they've been conducting drug sensitivity testing for moxifloxacin. If there's any resistance present, then another drug would be used instead. Adriana Chacon asks, why can't we use the BPEL-M or BPEL regimens in extrapulmonary central nervous system TB, osteoarticular or miliar TB, due to a lack of studies in this arena, or is there any evidence or experience that recommends not using them? The answer is for the central nervous system, bedaquiline has very poor penetration for the LCR. In other words, it's not recommended because there's no evidence to support this. I don't know if there's any other comments or any other questions that Dr. Rafael or Alberto want to mention. The question was if any patient had received a certain drug and whether or not there was failure, and we didn't have any reliable results, and the answer is no. The patient in this case received some of the drugs and they failed. Another question was, if I'm at a first level and we don't have the necessary resources to undertake pharmacovigilance activities, can we use BPEL? My response was, if you don't have a way to monitor the QTC, given that the patient has bedaquiline, pretomanid, moxifloxacin, that can complicate matters if you don't have the hepatic profile, then we've seen that this is frequently something that worsens the situation. If you don't have the linezolid impact or a way to assess this, then you should not be using that treatment regimen. You need to be able to undertake the proper pharmacovigilance to ensure that you cause no more harm to the patient than what they're already suffering. There's another question from Adriana Chacon regarding what experience the region has with regard to the 9-month treatment regimen. I would defer to Alberto to answer this because we don't use this regimen in Mexico very much. Yes, in principle, this is not a treatment regimen that is supported by the WHO. These are NTB studies. Apologies, the audio is intermittent. Sorry, Dr. Alberto, can you repeat what you said, please? Because we could not hear you. Your audio got interrupted. Yes, these 9-month treatment regimens are currently being evaluated in a larger trial, which is the NTB, that has about 5 branches of combinations. And we are conducting studies at the operational level in Peru and in some of these other countries using 100% oral mechanisms, but we don't as of yet have any results. We hope to publish the results very soon to be able to assess the efficacy of these regimens and whether or not we can add this to the current portfolio of treatment protocols. But we don't have any published evidence that we know of, but we do know that studies are underway. And the regimen with 7 drugs that include bedaquiline, and that also includes the injectable drugs. I think we're going to stop using this because this is going to be replaced by the shorter term regimens that don't involve as many drugs. So some of these have a number of drugs, many of which we don't use anymore. So we're going to start phasing these out in lieu of the new recommended treatment regimens. Yes, there's a question from Adriana Chacon towards the end that's related to the prior question related to BPEL. And if it doesn't fail, but there's a recurrence and several months later, the patients present symptoms, should we not use it in those cases either? Well, if a patient ends up being cured and then they get sick again a few months later, then what's likely is that we're talking about a failure, not a cure. Alberto, I don't know, what do you think? I think that if there was a previous exposure, it may not be attributable to these BPEL regimens. If you have XDR, we can't go with an oral treatment protocol. And the study presented by Rafael already indicated that we had seen in some cases some primary results. So there was a certain threshold of resistance to bedaquiline that wasn't that high, but more and more we're starting to use bedaquiline. But if you have an XDR case, you could go and eliminate all the short-term regimens. You need to go to the long-term. As we mentioned previously, this is something that's handled by WHO, but if we don't address these issues, then we're going to fall back into the bad practices from the 80s and 90s, and we're going to see a lot of negative impacts because we have current management practices for established patterns that we've observed over time. I think that what you just mentioned is extremely important because the goal would be to have a unique treatment for all sick patients, but this could lead us along the wrong path also. And the only thing we'll achieve with that is that we're going to create greater resistance to these new drugs that have really taken a great many years to develop, and we need to try to take care of these drugs. And the best way to do so is by conducting laboratory testing to know whether or not they can be included as part of a solid, reliable regimen, because if they're incorporated into weak regimens, then it won't be very long before the resistance develops for them. We have different interference or conflicts between some drugs with bedaquiline, for example. So it's a real issue, and we cannot set aside the laboratory testing. I know that some countries have issues in trying to implement the adequate laboratory facilities, but that's part of the goal. We can't just take that step, come up with a super regimen that doesn't consider the actual conditions for the patient. That doesn't work. There's another question. Is it not recommended to use these existing regimens and more favorable to use the new drugs? I think that the WHO was very clear with regard to this. First of all, we need to implement these reliable regimens as soon as possible. Nevertheless, if the patient's life is at risk or at stake, then we need to consider other recommendations and other data. For example, the medication history, the sensitivity of the contact, the resistance patterns that exist in the region or locally or at the national level. And this allows you to come up with a clinical decision. And everything needs to be done with a view to ensure the best outcome possible for the patient. We can go with these susceptibility tests, but the problem is that not all countries have these. And so if you have a resistance issue, then the decision there is to look at the entire picture, all the elements. Otherwise, we can't really face these pharmacovigilance or drug-resistant issues without proper laboratory testing capability. And this is something that Rafael already alluded to. I think that we're experiencing an unbelievable time frame in as regards to laboratories, because in a very short time period with a few cartridges, we can have in as little time as 4 hours information about whether a patient has MDR or RR or XDR. So many countries, they don't have the capacity or the resources to set up a large TB laboratory with all the assets and the equipment necessary. We've taken molecular laboratory testing down to the contact point with patients. So this is no longer out of reach for many countries, and many countries need to set that goal for themselves. I need to be able to put these tools at the point of contact with the patient. Many times you have these things in the national laboratory, and then these things have to be transported out to rural areas and what have you. But now we have a rapid way that allows us to determine which cases are complex. And the idea would not to be experimenting with those patients, but to collect more evidence and then send it to a national laboratory. But if in the first contact at a clinic, the patient can have results or answers that same morning, then that would be awesome. And we have these extremely reliable devices with very reliable cartridges. I agree with you. Sometimes we have to be empirical in our application of treatments because we've got patients on their deathbed, and we need to do the clinical work necessary to save the patient's life. But many times at the national level in our country, we might say, well, you know, the patient was very sick, and then it turns out that they weren't that sick. And many times people say it's too much work to conduct the testing, and it isn't. And the goal for us would be to ensure that all countries have this rapid molecular testing technology so that they can get real results in real time. Thank you. We have another question here. When you treat RRTB for the central nervous system, we currently have the 18-month strictly oral regimen. Do you foresee that in the next few years we'll be able to use this in a shorter term? And is there a fifth drug for lower levels of bedaquiline? Well, this was something addressed by the WHO last year to come up with a different alternative treatment to the conventional treatment. And it's part of the explanation included in the guidelines, what cases this is indicated for and which cases it's not. This is something that's been determined to a great extent for central nervous system cases. We also have hospital facilities and we have Dr. Jailot from Colombia. And we could use different doses in effective ways. So we could probably use a better regimen based on what Rafael was just talking about, as long as we can have the adequate evidence. We could use the hierarchical tables that we have available, and based on what we see there, we can identify the best combination of drugs to be used with any patient.
Thank you. There is a comment from Maria Rodriguez. For the long-term regimens, do we have to reposition BPM? There's another comment from Maria Rodriguez on the BDQ comes in bottles of 188 tablets. This means 24 weeks and is a difficult operation. For 26 weeks, you need 200 tablets with the doses of Monday, Wednesday, Friday, and 238 in those that take it daily. Excellent comment, what Maria says. It has been recommended 400 the first week, the first 2 weeks, and then 200 the next 4. But in the test, we use a different term, 200 the first week, and the quantity increased as the regimen proceeded. So it has to do with the presentation of the product. So it is important to emphasize that the presentation is important. Now, the difference between both, there is no definitive evidence that favors one or the other. So there is that limiting factor for the moment, but we should treat bedaquiline the same way, 400 for the first 2 weeks and then 400 for the next 4 weeks, which is good for the manufacturer. I agree with you on the carbapenems in patients with XDR. These are going to play an important role. Peru has worked on this, and their teams are very used to using this medication through a catheter, and they've done it very well. In some countries, that presents a program obstacle because you have to have people who are trained at handling a catheter. You have to give 2 doses a day, so that means 2 visits to the patient's home. But that these are excellent drugs, there's no doubt. Now, what we need to do is not have too many XDRs. And if we do have them, learn from what Peru has done with their own team for administration of the drugs through a catheter. Thank you. There's a question from Wilson Cox. Could you expand why the short 9-month treatment with bedaquiline is not recommended when there's resistance to INH and mutation of INHA and CAT-G? Because the system is set up, if I have resistance to xenocide with INHA, I give a high dose of sonocide and overcome that exception. If you have CAT-G, xenocide is not going to function, but the other one will. But you have both resistance to L and X, then the bacterial effect you wish to obtain from this regimen is going to be lost. So if I have a genotype that says that it's resistant to cinnamicide, and you have both INH and CAT-G, then the oral 6 months system will not work. It must be BPAL, and if it doesn't, then we have the long individualized treatment where the doctors will decide what is the best regimen according to the WHO hierarchical table. I agree with Alberto completely. Thank you. There's a comment from Dr. Castro. In the case of relapse after a successful treatment, is it worthwhile to assess the strain of tuberculosis to determine whether it's really a relapse or a reinfection? Well, unfortunately, these genotype evaluations, his microphone is frozen. Sir Alberto, could you start all over again? Because you were frozen. Can you hear me now? They definitely should do that, but this requires a much more sophisticated laboratory to keep the initial strain and then compare it to another strain and do clinical tests. It's very difficult to have those kinds of programs in place. Another comment for Dr. Kenneth Castro. I agree with Rafael. Our countries in the Bajo region should give priority to developing laboratory networks to obtain universal resistance sensitivity to antimicrobials and have universal tests. What's on the goals of the WHO? I agree completely. In fact, I think in the last year, we've made a great deal of progress in the setting up a lab network to have rapid molecular tests, as Rafael mentioned. Pretty much all countries in last year, between 22 and this year, have acquired the new version of the GNSPR equipment with 10 colors, and therefore they have full capacity to use the expert XDR, and which would therefore confirm the diagnosis of MDR to resistance to isoniazid. And also what's useful in pre-XDR cases is resistance to fluoroquinolone. I think we can now start changing, and as has been said in other occasions, the genotype that is ours are counted because of how laborious it is to use that kind of technique in the laboratories. And we can now start moving completely to provide universal access to sensitivity tests confirmed through a resistance test for rifampicin, and anyone who has resistance, that to guarantee that 100% of the cases, we would use a sensitivity test to phenylaquilone. You'll see that we are still under 50% in reaching that goal. Thank you, Ernesto. There's the last question on good practices. Can we continue using pyrazinamide for individualized regimens, knowing that it has a good sterilizing function? Dr. Rita Garcia asked this question. The recommendation is that if the tests that are not very reliable show resistance, then don't use it. There is now a molecular test. I don't have any experience with it. Perhaps Ernesto could comment on it. That may be better than the phenotypical tests we have now for pyrazinamide. But if there is resistance reported, the recommendation is not to use it. Ernesto, how does this molecular test work for pyrazinamide? Rafael, even Alberto could perhaps confirm this, but it has always been said, even recently in Pepe's courses, he's always said, well, we now have an URIPA molecular test to detect resistance to pyrazinamide, but it would be useful to find out what the resistance to pyrazinamide is so it doesn't interfere in the treatment. I don't think this is therefore a priority. First of all, because of the difficulty using conventional methods, which were not reliable in detecting resistance to pyrazinamide. The new method that's come out into the market, recommended by WHO as a highly complex method, the way they classify molecular methods, which are low or moderate complexity with centralized platforms, and then high complexity, which are the ones that are classified NIPRO, which is a type of NIPA because of the lab requirements. So we don't think it's a priority to determine resistance to pyrazinamide. Thank you. I don't know if Dr. Mendoza has any comment on that. Similar to what Ernesto said, the sensitive TB, when we lose pyrazinamide, we can prolong the treatment regimen from 6 to 9 months, and it should go well. Pyrazinamide had a vital function in reducing the system to 6 months, but in MX and XDR, things change, and we've used it a lot because we didn't have many drugs to use. You know now that group C is very low, and very often when you reach that stage, you've already used pyrazinamide before. So its usefulness, TB-MR, under current conditions may not be very useful, since there are better drugs and better regimens, and the individualized, it may depend on whether the patient was exposed or not to pyrazinamide. And in Latin America, most likely he was. And if he has used it, it may be too late to use it in an 18-month individualized regimen. Thank you. I have another question that Dr. Laniado had responded to in the Q&A, but we wanted to share with everyone what practical strategies are there for monitoring adverse reaction in the use of BPAL under primary care, where we do not always have timely access to specialized exams. And the answer was that if you don't have the elements to monitor prolongation of QTC, beta phenomenal moxofenamine that prolong the QTC, then the hepatic function of beta-equivalent with moxifloxacin and optic nerve should not be used with BPAL. Do you have any comment on that, Dr. Mendoza? In that case, you'd have to treat the patient. You can't leave them without treatment. We have to see how we can use local resources and move the patient to a second level or third level, but you have to start treatment. But under pharmaco surveillance, because we have to save his life, but we can expose him to being blind, have a hepatic problem or anemia with serious complications. So it's very important to train human resources, doctors, nurses in the country to this system, and then have a reference system. If I don't have an electrocardiogram, find it in some other network, maybe at a reference hospital somewhere else, and transport the patient to test for that. So primary care should not be disconnected from the healthcare system. And we have to strengthen it. For tuberculosis, we have to strengthen the network to help them move a patient to a reference hospital. And this is valid for all second line systems that are much more toxic than the primary regimens. And because the drugs included have great toxicity, there will be a webinar on pharmacosurveillance, which will be crucial to understand the protocol that a patient has to be given depending on the drugs included in the system. But as Alberto said, we can't leave them without treatment, because if at the first level that patient cannot be treated at the first level, they have to be referred to a second level so that the patient can start a safe treatment program. Another question is, what do you estimate the leap for BPAL and BPL-M treatments? The response could apply in all 4 groups. And finally, we have a question from Diego Marcias, and I think it's for Pier Paolo. And the question is,
what are the greatest drug safety concerns or safety uncertainties of these treatments that should be better studied during the post-authorization?
Yes, thank you for the question. I replied before. So actually, the clinical trials didn't start yet. So this is something that is going to be explored. The clinical trials are supposed to start with the enrollment of the first patients in September, October.
Okay. Thank you, Dr. Pierpaolo.
Thank you.
Very kind. Y bueno, finalmente tenemos muchísimos comentarios.
Finally, we have a lot of comments thanking all the presenters for their presentations, and they all agree on the importance of these new regimens, shortened treatment regimens to increase adherence. A last comment from Dr. Castro, who agrees that the treatment of persons with tuberculosis without knowing the results of antimicrobial resistance should be considered as a past and inexcusable practice. I think that's all for now in terms of questions and answers. Pedro? Francisco has the floor first. Thank you. Thank you very much to everyone. We are very pleased with this excellent participation we've had in this first meeting. More than 250 participants from more than 20 countries. So we're very happy with this wonderful participation. And we would like once again to extend a very cordial invitation to all participants to attend the following webinars we'll be hosting on drug-resistant tuberculosis. In the next seminars, we'll have a session on the treatment of sensitive TB and the new regimens that are being recommended to support treatment and experiences countries have had on treatment observed via video. We'll also talk about universal access to diagnostic tests to the management drug-resistant tuberculosis in children, on active drug surveillance, and everything that has to do with the administration of strategic fund. So we have a better understanding and more knowledge to make better decisions in the management of tuberculosis in each one of our countries. Finally, I'd like to allow Dr. Rafael Añao and Pedro Aderillo to say a few closing words. Rafael first, and then Dr. Aderillo. Very briefly, thank you to everyone who was connected to the webinar. I'd like to invite you to join us in the next webinars, and we'll tell you about them with plenty of time in advance. Thank you for PAHO and WHO for organizing this webinar. Alberto? I also would like to thank Rafael on behalf of the Green Light Committee. We have a lot of plans for this year with the regional team to be able to move forward implementing these systems correctly in our countries. So thank you very much, Pedro and Francisco, Ernesto, and Monica and the whole team from the regional office in Washington and the colleagues from Italy as well. I think this has been an excellent webinar, and I'm very pleased with what we've heard and the comments and questions that were asked. Excellent questions. Thank you. Thank you very much, colleagues. I'd like to join others in thanking you, specifically Rafael, Alberto, and all the regional Green Light Committee for the excellent presentations and the continuous support you provide. And also thank our colleagues from the University in Milan, Pierpaolo, Giuliano, Simone, and Mario for sharing with us the progress they're making in their research. And we hope to be able to have them participate in future sessions to tell us what progress they're making and what is the status of their research. I'd also like all the colleagues of PAHO and the interpreters as well. And particular thanks to all participants who have shared their comments and questions so that we can all learn more. and again, emphasize that we're working on the translation of all WHO guidelines. They will be available shortly. We'll share them with you. We also will send you the recording of this webinar as well as the presentations. We'll send them by mail to all who registered, but we will also open a spot in the WHO webpage where we will place all the material so those who could not participate today can see it. We also will inform you by email of the next virtual sessions we will be hosting, which Francisco referred to, and which we intend to organize with the committee, and emphasize the importance of working to speed up the implementation and expansion of these new recommendations, these new regimens, and the sensitivity tests. And remind you that at PAHO, we are ready and willing to continue supporting you technically in these process. Without any further ado, thank you very much to everyone, and we wish you a nice day. And now I would like to invite colleagues to turn on their cameras so we can take a group photo. Thank you very much.
Bien,
Gracias.
muchísimas gracias a todos. Hasta nuestro siguiente webinar. Buen día.
Adiós, adiós. Saludos.
Thank you. Goodbye.
Thank you.